Thank you. Dr. Mubarak will present the
Yeah,
team.
thank you so much, Doctor. Thank you so much, and welcome from the Cath Lab at Heart Health Center from King Saud Medical City, Riyadh. And thank you for the GIST Society and for the organization committee for this opportunity. I'd love to introduce our amazing team. I'm joined here with Dr. Hatem Aloui, the director of the Cath Lab. He will be the main operator of this procedure, and Dr. Hazem Rahbi, who's the head of structural in the center, and he's going to interpret the imaging analysis. I'm joined also by scrub nails, Abdurrahman Mlafakh and Bassam Shaghi as radiographer, Sifiti Nasr Bil-Libda and Abdulaziz Asiri, and also joined by Lester and Hailen as a nurse, and anesthetist Al-Amr. I will start with Dr. Hatem to present the case.
Thank you so much, Dr. Mubarak, and welcome all the team there in GIS. You can go. We will go through the case. We have chosen an interesting PCI LAD diagonal. Next, please. Next, no. Next, please. Directly the case. Directly the case, please. Next slide. So this is a 61 years old male who he is diabetic, he is hypertensive, and he has been admitted actually in the beginning of this month. He was referred to us from a cluster hospital for a non-STEMI. Next, it was actually, when we dig a little bit more in the history, it was a transient test elevation in the inferior leads. This is the ECG when he was admitted in our recovery with some, as you can appreciate, some STT changes in the inferior leads, no Q waves. Next, please. So these are his labs. Slightly increased troponin level on admission there in the class 3. It peaked up to 7,000. He is relatively well controlled in terms of diabetes mellitus. Creatinine is okay. This is his echo. Some regionality in the inferior territory. Good ejection fraction. And this is the angio. Next, Billah Hazem. The angio done at that date, so November the 6th. This is the left system. Next, please. So the caudal view. In the cranial view here, you can appreciate a moderate lesion on the osteoproximal LAD and a significant 011 lesion on the bifurcation LAD diagonal. And in the next view, you will see that it is much more significant. Next, Hazem. So clear significant lesion in the LAD just near to that ostium of the septal immediately after the diagonal branch. Next, please. Nothing relevant in the spider view except a small circumflex. Next, please. Next. And this is the culprit lesion, actually, that was the mid to distal RCA. Next. The TME3 flow with the quite nasty lesion. So our buddy and friend Hazem did the PCI at that time. So he put a drug-eluting stent, a Synergy 4x48, optimized IVUS guided and post-dilate at a 4.5. Next, please. And this was the result. Actually, as I said, it was a quite nasty lesion, thrombotic. So we had some slow flow at that time, but as you see, the result was excellent at the end. So the decision was to deal with the bystander lesion in another setting, not during the same setting. Next. So the patient was discharged on this medication, and he is readmitted today for PCI to the bifurcation LAD diagonal. Next, please. So our plan is to go for a PCI, of course, to the LAD diagonal. We will go, we can discuss about that. We'll go transradial, 7 French. I know that it is not really mandatory to be 7, but to get more comfort, and we can discuss about some, what's the interest of a 7 French here. We'll do an IVUS assessment for the proximal LAD lesion. We have seen that we have a moderate lesion, but just to be sure that if we'll be landing a stent in the proximal LAD, we will have a good landing zone there. And according to the IVUS assessment, we will plan our procedure. what we will do, what we'll choose as a management plan for the LED diagonal bifurcation. Next, Hazem. So actually, these are, in my opinion, these are the major plans that we can have if we'll be dealing with this diagonal. Either we'll go provisional stenting or elective double stenting technique, or we can go with a hybrid approach, a blended approach, DES and DEB, or a puristic approach, just DEB to the LED and the diagonal.
So
I
great,
think,
Dr. Hatem. Can I stop you there and
yes.
Let's have like few minutes to discuss it with the panelists here about how would they approach. I mean, you gave us like a few options there, and let us take the opinion of the panelists. How would they treat such a lesion, a 011 LED diagonal? So start with Dr. Habib.
Yeah, thank you very much. This looks like a very interesting lesion to treat. It looks simple, but it's not as simple as we might imagine, because we have a significant lesion in the LAD, obviously, and we have a sizable diagonal branch that is diseased with a quite long lesion. So we might consider to stent upfront that diagonal lesion. In addition to that, we have a plaque above the lesion that might.
Sorry, Dr. Hatem, can you put the vertical or the vertical view of the LAD?
Can you go back to the
cranial view? Sorry,
epicranial and the areocranial, Billah? Back
just
again.
the cranial view.
Back, Hazem. Back.
You can show the angio.
Yeah. Again once, is to have the full screen. Again, yes. Now run it.
Yeah, just keep it running
Just
and we'll discuss.
Yeah.
Yeah, just keep it running there.
You see, there's a plaque. It's not significant, obviously, just above the lesion, and if you place a stent over there, that lesion might look more exaggerated, and then you would maybe need to think what to do about it. So there are many questions to be asked, and I think imaging in this particular case is absolutely crucial, because it will, first of all, re-evaluate that plaque and to define what would be the landing zone for the stent of the LAD. Now, the question whether it would be a hybrid approach with stenting of the LAD and DCB for the diagonal, this obviously depends from the experience of every one of us. And my personal approach is to maybe start to prepare the lesion with a balloon and see how it looks. If it looks fine, then a DCB would be appropriate. Otherwise, it will be a second stent to be placed in that lesion.
Dr. Khalid?
Well, I think 011 is one of not the commonest types of bifurcating lesions, but as I agree with the literature, is the provisional stenting is the preferred method to go. I agree with maybe I'll do IVUS to make sure before the procedure that I have a good landing zone proximal to the lesion in the lady. If the vessel, it's reasonable, around 2 millimeter vessel, if has good flow, then I reassess it after expanding the stent. And for sure, I'm going to protect the vessels in case there is a plaque shift.
Dr. Wa'il?
Really an interesting case. I think, first of all, I agree totally that 7 French is, if you have a good radial, is a guiding of choice in most of the cases, especially bifurcation cases. For this case, I think that imaging will make a big difference, just to evaluate the osteoproximal LAD and the millimeter area there, although I think it will be more than 4. And for the diagonal, if you can treat it with the DEP or DCP, this would be the best approach and stent across.
Okay, Dr. Hatem, so you hear the panelist?
Yeah.
Yeah, so just tell
So,
us what's your plan and what you did.
next. So can we go next, Bilal? Next. So as you have said, we will be planning not to leave too much stent. So we'll try to be as simple as possible, but not simpler. So a blended approach for us is probably the best approach here. So our plan will be next. I don't know if the slide is clear. We will prepare both lesions as you have said. We'll prepare the main, we'll prepare the side branch. And according to the result, exactly as you have said, Dr. Habib and the rest of the panel, according to our result, if we have a good result on the preparation, a good preparation, here we have two options. Either we start with the main branch, we stand the main branch and we cross again and we apply the DEB, or we start by the DEB, with the side branch, I mean, we apply the DEB on the side branch and we finish by stenting pot without any kissing. If we have a bad result in a dissection or a slow flow, severe, I mean high-grade dissection or no flow, slow flow, at that time it will be a double stenting technique. We'll try to do a nano crash. According to the angulation, it looks favorable probably. But if it's not a favorable bifurcation for a nano crash, it will be a decay crash. So our choice will be for the second, next. So we are choosing to apply the DEB first. If we have a good result on the side branch, we'll deb the side and then stent across. So what we have done so far, of course, all these plan will depend a lot, as you have said, on the IVUS imaging. So we have done an IVUS in both vessels, in the LAD vessel, the LAD axis and the diagonal. And Dr. Hazem can show us the result, the findings on the IVUS. Go ahead, Hazem.
Yeah, hi, good morning. I think you can all probably see the screen. So this is the Avigo Plus IVUS system.
We don't see the IVUS, sorry.
Latest iteration from, you don't see the IVUS. Can we please ensure that they can see the IVUS?
Yes, now, okay.
You can see it, yeah. So this is, as said, we did this using the Avigo Plus system, the latest iteration from Boston. And this is a run of the IVUS and the LAD. You can see there's the new function, which is the automated lesion assessment. So if I can start from distal. So we're trying to find a good landing zone, and here very helpful to get the plaque burden, and you've got the assessment of the vessel as well automated. So you can sort of run and try to find a distal landing zone. So this is distal to the lesion, and we thought here we've got a plaque burden of 33%. So this may well be a good distal landing zone. And now I'm just going to scroll slowly. I'll let it play for you first. So this is all still distal to the lesion. And then you can start to see the diagonal wire coming here. This is the disease that we saw proximally in the LAD. Again, further disease. More disease here. And we thought, yeah, so I'm just trying to scroll. You know, it's a small circ. This is where the circ is. So we thought somewhere here, maybe we can land our stent proximally. Plaque burden, I think we tried to get an area better, about 40%. I think you have to get as close as you can to the ostium. Or the other option for us was to try to be very short with the pot and land somewhere there. But that will mean we're going to have to ignore this disease, which, as you said, it may get exaggerated once you stent. So this is the LAD run. But as Dr. Hatem discussed, our plan is really to start with the diagonal. So I thought I'll show you the diagonal run as well. So this is a run in the diagonal. And you can see distally the vessel is healthy. It's good size. There is some calcification. And interestingly, the ostium is relatively spared.
So amazing. I mean, the IVAS gave us totally different picture than what we saw in the angio.
Yeah.
So in the angio, we saw that the proximal LED looks healthy, but now we see that it's also, there is atheroma, there is disease there. And the ostium of the diagonal on the angio looks tight, but here it doesn't look bad.
Absolutely. This is really very important, and it can support our plan not to go for a stenting of that diagonal, not to go immediately for an elective double stenting technique, because we know that one of the major factors of occlusion of the side branch is a severe osteal lesion. So I think the IVAS here is really very helpful to set our plan appropriately.
Dr. Habib.
Just a question to the operators. Will this IVAS finding will change your strategy and how?
So it will support our first initial plan, actually, but it will be very helpful for us in choosing our our equipment, the diameter of the balloons that we will need to apply, the length of the pot balloon. We know that it will be very important to choose an appropriate length of the balloon for pot. So I have always a tendency to undersize the balloons when I go angiographically, and whenever I do an IVAS, I find that the vessel is always bigger and it needs larger balloons. So I think the IVAS helps us to choose the appropriate tools we have to apply to use in our procedure.
Dr. Khalid.
For the plan,
sorry, Dr. Hatem, let me ask Dr. Khalid here. Dr. Khalid, the IVAS showed the LED distally is around 3, proximally is around 4 for something. And the disease reaches also to the proximal LED. And also there is the question whether to use a short stent or a long stent. How would you tackle this?
Well, as you know, recently the literature has supported using IVAS in bifurcating lesions.
diagonal.
هذا هو 275 ها؟
يلا. And supported using imaging in the bifurcating lesions. And certainly it will change. One of the recent papers from the European Society in European Medical Journals is called Plateau Structural Protocol for Bifurcating Lesions. And I advise everybody to read that protocol where a group from Michigan put a protocol for structural lesions. And they emphasize, they published it like last month, on 25 of October. And they emphasize clearly the use of IVAS will make major decisions in bifurcating lesions. So, as an answer to your questions, I will never leave the proximal lesions in the LAD and the distal lesions. I'll tackle both of them, and I'll watch the side branch with the rewiring again. And for likely it won't be clued, but I will watch it.
Okay. So, Dr. Hatem, what you are doing now?
So we are starting preparing the.
Can we see the angio? We don't see the angio.
275.
So, may I have a comment, Doctor?
Can you open the angio, please? Yeah.
Let him answer, and then. So what you are using now?
So it's a 275 15 NC balloon, and we'll take a 275 cutting special balloon. So a cutting balloon.
Cutting.
I think it's the.
That's what
Yeah.
We always like to prepare very, very well these lesions, and using special balloons, scoring or cutting, so that we don't go very high in terms of pressure, and to have like a controlled dissection. We don't want to go with the high pressure 1-to-1 NC balloon and having spiral dissections. We prefer going low pressure with specialty balloons to have a controlled dissection and to allow the drag, if ever we will be putting a drag-eluting balloon, to allow the drag to go deep in the vessel wall. So this is a cutting balloon now, 275/15. Small test, please. I will push my wire. Go up, please. Slowly.
6, 8.
I think 275 by Ivis. Hazem, it was. This is 275, huh? Yeah.
Yes, it's a 3-0 vessel. It's a 3-0 vessel.
8
Yeah.
down.
So we are at probably 0.5 to 0.8 to 1. Small test, please. We'll do a prolonged inflation. Go up again, please. Eight.
Yes, 8.
Really, these new devices help, I mean, preparing the lesion before doing DCB. This scoring balloons, and also there's a grip balloon, and these new balloons
8
that
down.
you use it 1-to-1 to open the vessel before you do DCB.
I think theoretically it makes sense, and it might be beneficial. Now you have to prove that through data and studies, but when you think about it, I think it does make sense.
While the size of the vessel on Ivis is a 3.0, they used here 275. Would you use it like a 3.0 balloon, or 275 is enough here?
Yeah, for a cutting
air-
balloon or
air-
scoring balloon, especially cutting balloon, you need to undersize. So 275 is very good. I would go after, and the choice of cutting balloon here, because the Achilles here for DCP is preparation, vessel preparation. We had, and from Ivis, we had some calcium and fibrosis. So it is a balloon of choice for me. And then I would use an NC3O on a nominal pressure, just to make sure that the vessel is really nicely prepared, and then apply this.
Yeah. Go ahead, Sine. I think we still have some work to do on the diagonal. What do you think?
Yeah, I mean, Dr. Wael from the panelists suggested that after, cutting balloon, you use a 3.0 NC balloon.
I agree.
Yeah. Give us
So let's take
3-0.
3.0 15, please. 3.0 15. But we'll go, of course, just nominal, not high pressure. The vessel is only 3.0. So nominal 3.0, long inflation. Probably 30 seconds.
Yes.
What's your strategy if there was, after using the NC balloon, there was a dissection, distal dissection? What are you going to do?
So it depends actually on this dissection. How is it? Go up. If it is a bad dissection, I mean we have
What's nominal?
a dye staining, we have a slow flow. I will try to go nano crash, even though the angulation is not really very good for a nano crash. Otherwise, it will be a DK crash.
So some DCB expert, they love dissection. Okay, they say if they see dissection, it's a well-prepared, lesion before DCB.
Absolutely.
Yeah, but Timmy flow should not be affected.
Small test again, please. Yeah,
Regionally
go up again.
what?
Yes, I'm going more distal.
Yeah.
One thing that we're not used to when you have a bifurcation lesion like this,
Yeah.
is to focus on the diagonal first before
Down.
even tackling the main vessel. Usually what we do, we focus on the main vessel
Small test.
and see what happens in the side branch.
Not
And
very
then
bad.
treat the
Go up again,
side
please.
branch later on. But
I
here
do-
we see,
I
we
do
see a
agree.
different approach.
I do
Yeah.
agree.
I think that the strategy using DCP, crossing
14.
through the stratus with a DCP, you may affect the efficacy of the DCP.
Yeah.
اربو اسود.
Down.
So this is a 3O NC.
So this is a 3015 NC, multiple long inflations. We try to cover the whole lesion, but sparing actually the osteum. I think the osteum doesn't need to be traumatized. We'll just apply the drug on it.
بعطيك هو اسود.
So what kind of DCP are you planning to use, or it doesn't matter for you?
I would use here a solution actually.
Yeah.
It doesn't matter too much, probably just if we take some results of some new trials, but technically here it doesn't matter. If it would be something difficult to cross, as you have said, if I was planning to do it after main branch stenting, I would choose a DCB that has a good crossing profile and a good trackability. So, but here, although the solution is probably one of the best in terms of trackability, crossability,
320.
but this is not really
length.
the reason why I'm using it.
Why your question about the drug itself, or
No, but solution, because of the latest data from solution
Yeah.
Lenovo, it's really it's a sustained release of the drug makes a difference.
paclitaxel?
Era
Or?
DCB, huh?
Yeah,
It's
yeah.
sirolimus
3O20.
base, but it's
Nice.
the way they apply the drug with the micro reservoirs. It's really unique.
And you have the results of the scar registry as well.
Yes, it's very good results. So bifurcation
Yes.
lesions
Okay.
was
So
not
now we are going
included.
with the DCB.
هو اسود.
What's the size and the length?
So it's a 3020. Small test, please. I think we are fine
Yeah.
here. Go ahead.
تايم اربو نومينال كم 8
Okay.
For how many seconds?
Wallahi, we will stay 60 seconds. If the patient tolerates, of course, no chest pain, no chest elevation.
Actually, for this balloon, especially, they have data that 30 seconds are enough. But as Dr. Hatem is doing, we applied for 6 seconds. Patient is
Okay, down, please. He starts having some chest elevation. You see the relevance of this diagonal branch, actually. Okay. Nitro.
Yeah.
How many seconds you?
Close the ring, huh?
I think it was only 40 seconds because he started having chest elevation, so we stopped the inflation. I think it's enough, as you have said. 10 seconds, 15 seconds are enough with this technology. Prime. Okay.
يلا ready.
Go ahead. Bismillah. What do you think?
Looks good.
great.
Looks
Looks
good.
good. Yes.
And it will grow anyway.
I
It
think
will
we have
grow.
absolutely. We don't have any dissection. The residual lesion is definitely less than 30%. So I think we can focus on the middle AD.
Yeah.
Okay, Hazem, what's the balloon we take
Yeah,
according
so
to the IVUS?
according to the measurements that we made, I think you can go with a 30 NC, 3020 NC to start with.
Yeah. I think it's a little bit calcified as well. Probably.
Yeah, exactly. I think I'd go with NNC. Then I will use a cutting. 3-5 cutting would probably be good.
Can you give him phenylephrine? He's not tolerating the nitro.
Yeah.
150
في ناس يا شباب.
Okay, let's take an NC balloon.
Are you going with a short stent or a long stent?
12. I would start with a short stent بصراحة.
Give us, yeah. الأول we'll use the briefest one, huh? 3-0.
Yeah, okay. What's your thought here? Should we go with the long stenting? Or should we
why we
stop
don't
at the
leave it without a
proximal
stent?
and look at...
Do we need to stent to have the drug eluting?
No, not the diagonal.
Which one?
The LED.
Oh,
We will use the cutting balloon
just
again?
give me the wire.
Yes.
You know, the question now is use a long stent or short stent?
Of course, long stent.
Long stent back to the proximal?
And you have to cover the lesion from this.
Short stent, you mean after the takeoff of the diagonal? I mean, precise stenting?
No. I mean, he's going to use across the diagonal, but not go back to the proximal.
You need to have enough length to have your part. So this,
Yes.
You have to do it across the diagonal.
So, Dr. Hatem, let me just understand your question. When you say short stent or long stent, you mean short stent across the diagonal or long stent back to the proximal LED, right?
The ostium, actually.
Absolutely, yes.
Okay,
Absolutely.
so in both cases, you're going
LED?
to stent across the diagonal.
Yes, but this is what you mean.
Absolutely, yes.
So my question is, Dr. Hazem, this vessel, the 3.0 measurement with IVUS, it is a lumen to lumen
14.
or media to media? Because it looks like a 3.5 for me.
Down.
Yeah.
14 down.
So let me answer you. So distal vessel, if we want to go media to media,
Okay, go up. Okay. Down.
yeah, I would say it is 3-5.
Yeah, I think so. I think it's 3.5.
Yeah.
That's better, Ola.
The IVUS.
Bon, better.
Oh,
The more we go,
We have a nice.
yeah, the larger we go, the more we have risk on the side branch, of course, but
No, the branches.
oh, yeah.
okay. I think we will cut as you have
Yeah,
said.
yeah.
You want a 3-0 cutting or?
3-5 probably
3 to
cutting.
5, maybe.
3-5 cutting.
Hatem, what was the balloon used now in the
3 to 5
LED?
Java.
Unless
It was a 3.015 NC balloon, but as you have said, it's probably undersized. So we are going to upgrade by
and it has to be
0.25 using a cutting, a short cutting balloon, because as you have seen in the IVUS, there is some calcium there. It's a fibrocalcified plaque, so better to open it very well. And when you open it very well, actually, you know, the major factor for carina shifting
Cutting, huh?
is the shifting of the major factor for carina shifting is when you push the plaque and the vessel at the distal part, you push it on the carina. So here you
Dr. Hatem,
prepare
there
very
were-
well that part. I think
Yeah.
it will be more compliant.
There is a question
And
from
we will
one of the
have less risk of
panelists.
carina shifting.
Why use cutting here?
Yes.
Why use cutting? It doesn't look,
Yeah, it's.
Yeah,
I don't know if you
tough
see it
lesion.
in the angio. There is some calcium there. Go up. There is some calcium there. By IVUS, there is as well some calcium.
Yes.
Next. We want to prepare it very well, actually, and we want to avoid carina shifting. So I believe that by cutting this plaque, we make it softer, we make it more prone to expand and have less risk of carina shifting.
So
Down.
would you prepare the proximal segment also because it has a significant fibrotic disease and some calcium before stenting, or you just direct?
I will try. No, I will try to land at that aneurysmal part, as you have seen. The proximal part, proximally to the diagonal, there is no really severe narrowing. It's more about positive remodeling.
Yes.
So بالعكس يعني with the positive remodeling we know that these lesions are more unstable, more vulnerable. So I really don't want to go high pressure to manipulate too much there. And we have actually learned that very hardly in the STEMI actually more. You know, when you have a bifurcating lesion, you have an excellent result of your bifurcating stenting. And at the end, you go aggressively with an aggressive pot and you destabilize everything and you have an oriflow. So even when you do an OCT, always the proximal part is very vulnerable. We just want to apply to oppose the stent on the proximal segment without being very aggressive there, unless, of course, we have a severe tightening. But here, I don't think that the lesion is stenotic. It's more about positive remodeling there. So my aim is just to put the stent there to do an appropriate pot, just enough to have the struts opposed there. And then to look at the proximal LED, how is it? If, as said Dr. Gamra, it get worsened, we'll probably go ahead and complete the stenting. Otherwise, if we have a good result, we just stop there.
I totally
So
agree.
according to the IVUS, if we gonna in terms of length,
Do a scene.
I think at 3.524 it's probably
معلش.
Any comments on that?
Yeah, the area was 10 as the ostium, so it's you can skip it and give the patient aggressive risk factor modification like PSCK9
Yeah.
and it would do the job.
Can you go Ario 30-30, Billah? Someone can say why not a puristic approach here? A DB as well on the main. We'll see in another view how bad and tight. Yeah, it's tight.
Well, there
We
is
can't apply a DB. Yeah. What do you think again on the proximal lesion here? It doesn't
What
look.
I mean,
Nice.
it's a mixed, opinion here. I mean, personally, I would just stent across diagonal, not go back to the ostial LED.
Yeah.
Some people will say, okay, go back one stent, do the job back to the ostium of the LED. But I don't think it's very tight, not angiographically and not on IVUS also.
yeah.
Okay. I fully agree. I'll go across the diagonal.
Yeah,
You
and
can see
I-
the result, and there is no harm to cover with minimal overlap if it really looks bad after the stenting, or we can follow the patient later on. He can be followed very closely, and if you have any symptoms, we can go again and complete the job. Team, what's your opinion, Dr. Mbarak, Dr. Hazem?
I think I agree with you, Abu Harun. Dr. Hatem, I agree. I think you stent and then you assess, because if you really want to go healthy to healthy, you're probably going to end up using 2 stents anyway. So I would go with a shorter stent, assess on IVUS. If we're happy with the result, good landing zone, less than 50% plaque burden, probably leave it and follow him up closely. Otherwise, yeah, minimal overlap. And now with the new generation stents, most of them are thin struts, the synergy particularly, so you can overlap safely.
Okay.
Yeah.
What stent can we take?
So what's the link there if you want to use the short-term
Yeah,
strategy?
so what
it
I
24?
what I measured was just over 24. So 28 probably be good,
Okay.
because you've got plenty of healthy landing distally. So I think it's probably safer to take a 28.
Yeah.
Okay.
You would go with
It's
a
very
3.0 or
important to
3.5?
choose the length. No, 3.5.
3.5.
3.5.
We'll go with the
3.5.
3.5.
3.5 28.
And as I said, it's very important to choose the appropriate stent length
AC.
to get a nice pot, to get a good distance for a good pot proximally.
So let me ask the
A
audience
3.5
here.
stent as well is important.
Let me ask the okay, we
to
have
know
one
the
question from the
overextension.
audience, Dr. Abdullah Shahab.
ACT.
يعطيكم العافية
Exactly.
دكتور حاتم دكتور and Hazem. So what's يعني concerns here? Is it that focal lesion of LAD? That's why you want to do a stent? Or why you want to put a stent?
Oh, الويربو.
Why you don't want you?
Why you want to put a stent? That's my question.
So what?
Go cranial, please.
hold
Dr. Abdullah Shahab is one of the Gulf expert in DCB here, and is also favoring DCB. So the question here: why would you use a stent in this big vessel and not do only DCB?
Yeah, you have seen we try to prepare very well the lesion, Dr. Abdullah. So we went with an NC and we went with the 3.5 cutting balloon, and the residual lesion, actually, I don't like it too much. We have more than 50% residual lesion. If the result was good by after lesion preparation, I would definitely not stent it. But I'm not happy with the residual lesion. It's like we haven't done any progression. You have probably seen the result in the AP cranial. It was good, but when we changed the view in areocranial, it was really significant. Yes, please.
And as we saw yesterday also, we're still missing the evidence about DCB in big vessels. So
I can go a little bit more
down.
distal. I think I'm missing the lesion down, and I will be traumatizing the plaque proximally.
Another
Small
comment
test,
or
please.
question from the audience?
Assalamu alaikum, Dr.
Okay,
Hatem,
that's
Dr.
fine.
Hazem.
Wa alaikum
It's
assalam.
well
Test.
done work. I am really a bit against
Okay,
Dr.
go ahead.
Abdullah Shihab opinion
And up.
because you can
Yeah.
see from this, I have a good
What's the
experience in
stent
DCB.
size?
There is significant recoil of the vessels after DCB and cutting balloon. So I would really prefer to
Nominal.
even secure the diagonal because it caused some
Down.
ST changes. I would really go for two stent strategy rather than one stent because there is some recoil in the diagonal as well. So it seems that DCB here is not a good choice.
Some people.
Yeah, we're gonna see now.
Prepare
the
408 and see.
the stent was deployed at what pressure?
408 يا شباب.
What
12.
pressure?
12.
The vessel
Nominal.
is 3.5, so we went
Yeah,
just nominal. And now we will put with the 408.
So let's ask the audience show of hand. Who would have used a longer stent back to the ostium? Okay. Who would use the same strategy
Cranial,
only?
please.
So majority favors your strategy by using a shorter stent.
Okay. I have the wire.
Yeah. What's be ready?
What?
So it's very important to position the balloon appropriately here. Test, please. What balloon it is?
40 by 8.
It's a sapphire. So
Yeah.
test, we need to have to take into consideration the shoulder of the balloon. Go up, please. So proximally, let's see proximally how we are. Let's do a boost. Boost, please. So we have two major important elements here. It's not to protrude back before the first strat and not to protrude beyond the carina. So I think proximally we are not bad. Distally, small test, Abdurrahman. Yeah, go up.
I think we are
I think
fine.
it's very appropriate. It's
Good
immediately
position.
before it's at the proximal arm of the bifurcation. You see the
18.
shoulder of the balloon. It's long شوية, but it's not protruding in the distal part.
20 down.
Boost again, please. Let's see if we have missed the proximal strut or no, or not.
That's fine.
Can you have the boost on the screen?
Looks fine.
Post is not clear.
We'll take a 3.5 NC balloon to post dilate distally. 3.5, 15. Careful, balloon.
You don't want to do imaging now, just before? Maybe you don't need anything else.
بصراحة you see شوية the stent looks dark شوية at the level of the lesion. So I think it's underexpanded there. I will just apply the NC there and we will do the IVUS, yes.
So you're gonna double check with the IVUS.
Absolutely, yes.
Yeah.
So the next step will be the IVUS, optimizing the stent. I won't do anything on the diagonal as we agreed from the beginning. We preferably not to finish with the kissing here.
جهز الايفاس جهز
So,
الايفاس
Dr. Habib,
Okay, go up.
Dr. Habib, what do you think
Up,
about the
please.
importance of
Just nominal
imaging?
12.
Because many of these cases, we see it every
Nice.
day in the cath lab, and sometimes we don't do imaging, right? We go, but I mean, in this case, exactly showed the importance of
Down.
imaging because it's strange.
Imaging,
Okay.
when it is available, I think it's absolutely key. And you have seen for this particular case, it has clarified many things. It has clarified that the ostium of the diagonal is not involved, which is absolutely key in the decision, the strategy decided. And it has also assessed the lesion proximal to the bifurcation. So it's
Take the
really
IVUS.
important to have it
يلا الايفاس الاسود
both before and after to check the optimization of the
You flush.
stenting, the
You
priming.
flushed, huh?
Yes. And even the new data in
You
the
flush it.
literature that imaging in bifurcating lesion make a big difference in preparing making your decisions and checking your
Fill the reservoir.
stent up position after you finish.
Well, I know in your center you do a lot of imaging. I mean, is there
Fill the reservoir.
For me,
do you favor like IVUS, OCT, or
I have the one.
I was in OCT. We know that with OCT we have better resolution, but it's on expense of the contrast amount. So, but usually I'm doing over 90% of my cases imaging based, and the only thing that when I will not do imaging, if there is an obstacle, financial
See the
obstacle,
IVUS?
Or
But-
calcification or difficulty.
no
This is the
calcification, I will
proximal.
do definitely do
distal edge.
imaging. Even there is a financial, I will write
you see the
no
IVUS?
calcification. I do
Do you see
imaging
the IVUS?
100%.
Can they see? Can you see the IVUS, guys? Sorry.
Yes.
so this is after balloon?
Yeah,
After
after post-dilatation
post-dilatation.
distally, we have no dissection distally and excellent expansion distally. The apposition proximally is good. That's the wire of the diagonal. Actually, it's not a strut, and that's the lesion, the proximal lesion. I don't think it's really significant. It's a nasty lesion. If we will be doing an OCT, it can probably be a TACFA, but we won't touch it, I think.
No, they did.
Okay.
Yeah, stent looks well opposed,
Yes.
and there is, you know, as you
Yeah,
said, there is
so
if you
disease in the
wanna keep the
proximal
IVUS
LAD,
from
but
the
it's not
beginning.
significant.
Yeah. So if we can go, gonna try to take you through again this automated
Take a nice
lesion
thing, that's just
assessment.
nice, bro. Just give me a puff to see how is the flow on the diagonal.
Yeah,
Before remove it.
Yeah, you can
just
see
wait.
very nice landed in less
Bit more
than 20%
Yeah, it
plaque
takes-
burden. And then if we bookmark this, you can also get the percentage stenosis like with OCT. So you can see we are over 100% expanded distally compared to the distal reference.
Okay, let's go cine.
But I like this
And
new
if we
Avigos,
walk
very
through
nice.
it,
Just-
It's nearly like OCTs with AI technology.
yeah.
Can you get a better image?
لا والريبيت دقيقة
Can you make it a big screen for the angio, please?
والريبيت
Can you make the angio big screen, please, Bilay, Sultan?
can you open الكونتراست يا أخي
It looks well done job.
So what do you
Yes.
think?
Thank you. We'll do a better image. Okay,
يلا
go
ربي.
ahead. Wallah.
Dr. Hatem, how much
think it's not
contrast
bad.
used?
How much now? 110, 110, I think. Basim. 100.
Okay,
100.
That's good.
So, great job, Dr. Hatem. I'd like to thank you and
you go, Kodum?
all the team.
Thank you so much.
We're going to leave you now and thank you very much. Hope to see you very soon.
Yes.
Thank you so much.
They
Thank you.
need,
They need a
round of
cover.
applause.
Yeah.
Well done.